Joints, they come in many forms, but at their core, joints exist to link bones together and allow movement. Some let you rotate your arm in every direction, some move just a little bit, and some, just like the bones in the skull, don't move at all. You don't really think about them until something goes wrong. When joints wear down, become inflamed, or stop working properly, even the simplest movement can become difficult. So why are some joints flexible while others are completely rigid? What makes one joint allow movements while another barely moves at all? And how do we actually classify all the different joints in the body? In this video, we will start by answering the fundamental question: what are joints? Then, we will go through all the joints in the body and classify them based on their structure and function. As we go through them, we will also highlight their clinical relevance, understanding how joint problems develop and what makes them vulnerable to damage. Hey everyone, my name is Time. I'm a medical doctor and I make animated medical lectures to make different topics in medicine visually easier to understand. If you would like a PDF version or a quiz of this presentation, you can find it on my website, along with organized video lectures to help with your studies. Alright, let's get started. So, what are joints? Just in simple terms, the point at which two bones lay adjacent to each other with or without the ability to move is called a joint. Let's visualize this. Here we see a bone, here is another bone. The point at which they lay adjacent to each other is a joint. Here are two bones, between them a joint. Here are two bones, between them a joint. And even, I will surprise you now, even between your skull bones is a joint. So joints come in different shape, and they are structurally and functionally different. For example, the shoulder joint is called glenohumeral joint. Structurally, we call this a synovial joint. Functionally, it's a diarthrosis, since it's a freely movable joint. And we subclassify it as a ball and socket joint, which provides free rotational movement. Between the articular surfaces of vertebrae, we got a facet joint, or zygapophyseal joints. They are synovial joints, functionally movable, so diarthrosis as well, but subclassified as plane joints, allowing only gliding movements. Okay, let's take another example. In the skull, we got sutures, or lambdoid suture is what we're pointing at specifically now. Structurally, it's a strong fibrous joint, and functionally, a synarthrosis, meaning joint that does not move. Does it make a little bit more sense why we classify joints now? The study of joints is called arthrology. Prefix arthro refers to joints, such as arthroscopy, arthritis. Suffix logy means the study of. So it's the study of how bones and joints allow or prevent movement. It, perhaps more than any other subject in anatomy, illustrates the close relationship between structure and function. Here we see the shoulder joint again, or the glenohumeral joint. Now, when you look at this, see all the components, connective tissue, how it's built. Some joints are built the same, and some joints are not. And that is why we have structural classification. Apart from that, joints within the same structural category can move differently, and because of that, we also have a functional classification. Structural based on the binding tissue, and functional based on movements. Now, structural classification names and divides joints according to the type of binding tissue that connects the bones to each other. Sources may differ a little bit on details on the classification system, but what the majority of sources agree upon is that there are three structural classifications of joints. There are fibrous joints, consisting of dense, regular connective tissue rich in collagen fibers. Cartilaginous joints, joined by cartilage, primarily hyaline cartilage. And synovial joints, which are not directly joined as they have a synovial cavity within an articular capsule. Joints can also be classified functionally based on the type and degree of movement they allow. There is diarthrosis, amphiarthrosis, and synarthrosis. These words have a Greek origin, but diarthrosis are freely movable joints, so all synovial joints are classified as diarthrosis. An example is a shoulder joint. Amphiarthrosis allows slight mobility. Most amphiarthrosis are cartilaginous joints, and examples are the intervertebral discs between the vertebrae. Synarthrosis allow very little movement, to the point that they really do not allow mobility at all. they are immovable joints. Can you guess an area in the body where those type of joints can be? Well, we got the sutures of the skull. Awesome. Just a side note, I'm not going to talk about them in this video, but depending upon the source you're studying from, joints can also be classified according to the number of axes of movement they allow into non-axial, monoaxial, biaxial, and multi-axial. Another classification system is according to the degree of freedom allowed. Others according to the number and shape of the articulating surfaces, whether flat, concave, convex, and so on. Lots of different classification systems, but in general, if you know this system I'm showing you now, you're good. You will understand everything. Alright, let's now focus on these three joints. And let's start with the fibrous joints. These joints are connected by dense fibrous connective tissue and lack a joint cavity, resulting in minimal to no movement. And there are three main categories under the fibrous joints. There are sutures, there are syndesmoses, and gomphoses. Sutures are immovable joints between the joints of the skull. Here's the skull. Between the bones of the skull are sutures, strong joints. In fetal skulls, the sutures are wide to allow slight movement during birth, and they later become rigid. Next, we have syndesmoses. These are slightly movable joints where bones are connected by ligaments or an interosseous membrane. Some of the long bones in the body, such as the radius and ulna in the forearm and the tibia and the fibula in the legs, are joined by a syndesmosis along the interosseous membranes. Make sense? This membrane serves to unite parallel bones and prevent their separation. Syndesmoses are slightly movable, right? Amphiarthrosis, we call them, functionally, as we saw earlier. Another example is the distal tibiofibular joint. Here we see the posterior tibial ligament, which is one of the three ligaments of the inferior tibiofibular joints. The others being the anterior tibiofibular and the transverse tibiofibular ligaments. And it kind of makes sense. Why do we not want them completely fixed like in our skull? Well, think about it. The tibia and fibula need to stay firmly connected to provide stability for carrying weight. And they need a little bit of movement to accommodate motion at the ankle joints. If they were completely fused, like the sutures of the skull, movement like walking or running would put too much stress on the bones and make them more prone to fracture. So having a slight amount of movement helps with shock absorption and flexibility. The interosseous membrane also serves as an attachment site for muscles and helps distribute force evenly between the two bones. For example, in the forearm, the interosseous membrane between the radius and the ulna allow for pronation and supination, meaning it helps you rotate your palm up and down. And have you heard about high ankle sprains before? You have probably heard about regular ankle sprains where people twist their foot and damage the ligaments around the ankle. But in a high ankle sprain, the injury happens at the distal tibiofibular syndesmosis, stretching or even tearing the anterior and posterior tibiofibular ligaments. This kind of injury takes longer to heal because the tibia and the fibula are constantly under stress when you walk. So, this is syndesmosis, providing slight movement which is crucial for function and injury prevention. The third classification under fibrous joints is called gomphosis. Gomphosis refers to the joint between the dental alveolus and the tooth root, meaning the connection between the mandible or maxilla and the tooth. As you can see here, the periodontal ligaments secure the tooth in its socket, acting as a fibrous connection. At first, it may seem confusing why gomphosis is not classified under syndesmosis, since both involve connective tissue. However, the key difference is in their function and movement. Syndesmosis allow for slight mobility, like the interosseous membranes between the tibia and the fibula, which helps in shock absorption and stability. Gomphosis, on the other hand, is a peg and socket joint that normally does not allow movement, except in conditions like orthodontic treatment or dental trauma. Interestingly, in early development, before the full eruption of teeth, the periodontal ligaments allow micro movement, which is why some anatomists describe gomphosis as a specialized form of syndesmosis. But in adults, it functions as an immobile joint, which is why it remains in its own category. Alright, so that was the fibrous joints in our body. Next, we have something called cartilaginous joints. Those are joints that are connected together by cartilage, allowing limited movement. Now, cartilaginous joints allow more movement than fibrous joints, but are still much more limited compared to synovial joints. Their main role is to provide structural stability while allowing some degree of flexibility. What makes them particularly interesting is that they also serve as growth centers in developing bones, which is something we don't really see in other types of joints. Now, cartilaginous joints can be divided into two main types: synchondrosis and symphysis. But before we go into those, let's take a step back and talk about the bigger picture, because in the world of cartilage, we actually have primary and secondary cartilage, and these two categories perfectly align with the two types of cartilaginous joints. So, primary cartilaginous joints are called synchondroses. These are joints where bones are connected by hyaline cartilage. The key thing about synchondrosis is that they exist early in life and are later replaced by bone through ossification. That is why they're often referred to as temporary joints, because many of them disappear as we age. A perfect example of this is the epiphyseal growth plates in long bones. These synchondroses allow bones to grow in length during childhood and adolescence, but once full growth is achieved, they ossify and turn into solid bones. Another example is found in the base of the skull, where synchondroses exist between the different ossification centers before they fuse. But not all synchondroses disappear. Some persist throughout life. A great example of this is the costochondral joints, which connect the ribs to the costal cartilage. Now, you might have heard that these joints provide flexibility for breathing, but that's not exactly correct. The costochondral joints themselves are immobile. They function as structural stabilizers. What actually allows the ribcage to expand and contract during respiration is the elasticity of the costal cartilages, not the joints themselves. Now, let's move on to the secondary cartilaginous joints, which are called symphyses. Unlike synchondroses, these never fully ossify. They stay as cartilage for life. What makes them unique is that they are made of fibrocartilage, which is more durable and resistant to pressure. This is why symphyses are typically found in high-pressure areas of the body that needs both strength and slight mobility. One of the most well-known symphyses is the pubic symphysis, the joint that connects the two halves of the pelvis. Normally, it allows slight minimal movement, but during childbirth, hormonal changes make the fibrocartilage more flexible, which temporarily increases mobility to allow for delivery. Another great example is the intervertebral discs, which sits between the vertebrae of the spine. These discs are typically a type of symphysis, and their role is to absorb shock and distribute pressure along the vertebral column. To summarize, synchondroses are primary temporary joints made of hyaline cartilage that allow for growth and ossify with age, while symphyses are permanent joints made of fibrocartilage that provide shock absorption and strength in high-pressure areas. And with that, we've covered the cartilaginous joints. Next, let's move on to synovial joints. Synovial joints are the most common and most mobile joints in the human body. What makes them unique is that they have a joint cavity filled with synovial fluid, which reduces friction and allows for smooth movement. These joints are found in areas where free movement is essential, like the shoulder, elbow, wrist, and knee. But here's something interesting. You don't move your elbow the same way as you move your shoulder or wrist, right? That's because not all synovial joints are built the same. Their structure and movement depend on where they are located and what function they serve. Now, even though synovial joints differ in function, they all share some basic structures. If we take a closer look, here is what we see. First, we have a joint cavity, which is filled with synovial fluid. This acts as a lubricant and provides nutrients to the cartilage. The end of the bones are covered in articular cartilage, a smooth layer of hyaline cartilage that absorbs shock and prevents bone-to-bone contact. Surrounding everything is the synovial membrane, which is the inner lining of the joint capsule and is responsible for producing the synovial fluid. And finally, covering the whole joint, we have an articular capsule, which is a fibrous outer layer that holds the joints together and provides structural stability. So that is the fundamental setup of a synovial joint. But depending on the location and function, Some synovial joints have additional supporting structures that help with stability, mobility, and protection. For example, let's take the shoulder joint. Around this joint, we can see synovial bursae. Those are small, fluid-filled sacs that act as cushions between the tendons, muscles, and bones, preventing friction during movement. And you will find these in joints that perform a wide range of motion and need an extra cushion like the shoulder and knee. Another supporting structures are ligaments. Ligaments are strong connective tissue bands that reinforces synovial joints and prevent excessive movements. Now, if we remove the humerus from the shoulder joint, we can see the glenoid labrum, which is a fibrocartilaginous ring that deepens the socket of this joint, making the joint more stable. This is another supporting structure. The hip joint has something similar called the acetabular labrum, which serves the same function. If we move over to the knee joint, we can see another really important supporting structure called the meniscus. Unlike bursae or labrum, menisci are fibrocartilaginous pads that sits between the femur and tibia, acting as a shock absorber. Because the knee carries the entire body's weight, it needs extra cushion, which is why menisci are crucial for knee function. Some synovial joints also contain fat pads, which are soft tissue structures that fill the spaces within the joints, reducing friction and adapting to changes in joint shape during movements. You see now that even though we've got all these different synovial joints in the body, they're structurally different. That is why we classify them into different types. The way a joint is built determines how it moves. Some allow a full range of motion, while others are more restricted to just bending and gliding. Let's go through them one by one. First, we've got a ball and socket joint. This is the most mobile type of synovial joints, allowing movement in all three planes: flexion, extension, abduction, adduction, rotation, and circumduction. You can see this in the shoulder joint and the hip joints. The structure is exactly how it sounds. A rounded ball-shaped head fits into a concave socket, making it perfect for high mobility. But with great mobility comes great instability. The shoulders, for example, is prone to dislocation because the glenoid cavity is shallow compared to the large humeral head. That's why it relies on ligaments, muscles, and labrum for extra stability. Then we have the ellipsoid joint. This joint allows movement in two planes: flexion, extension, and abduction, adduction. But no rotation. A great example is the wrist joint. The oval-shaped articular surface of the radius fits against the ellipsoid shape of the carpal bones, allowing movement like bending the wrist up and down or side to side. But notice it can't rotate as freely as in a ball and socket joint. Next, the saddle joint. This one is shaped like a saddle, where one bone fits into another like a rider on a horse. This type of joints is found in the thumb of the carpo-metacarpal joints, between the trapezium and the first metacarpal. What's cool with this joint is that it allows opposition of the thumb, which is essential for gripping and fine motor control. Without this joint, you wouldn't be able to pinch or grasp objects properly. Then we got the hinge joint. This one only moves in one plane, like a door hinge. It allows flexion and extension, but no side-to-side movement. You will find hinge joints in the elbow, the humero-ulnar joint, knee or tibio-femoral joint, and the interphalangeal joints, so fingers and toes. The structure is simple. A convex surface fits into a concave groove, which is reinforced by strong ligaments that prevent excess movement. That is why your elbow doesn't hyperextend easily. The ligament stops it. Next, the pivot joint. This joint allows rotational movement around a single axis. A perfect example of this is the atlantoaxial joints between the C1 atlas and C2 axis. This joint is what lets you shake your head no, because the dens of the axis rotates within the ring of the atlas. Another great example is the proximal radio-ulnar joint, which allows the forearm to pronate and supinate. That's how you turn your palm up and down. And finally, the plane joint. This one has flat articular surfaces that glide past each other in small gliding movements. You will find these in the acromioclavicular joints, intercarpal joints of the wrist, intertarsal joints of the foot, and the facet joints of the vertebrae, or the zygopophyseal joints. While they don't allow much movement individually, when combined, like in the vertebral column, They contribute to flexibility and movement. So those were all the type of synovial joints. Each one is designed for specific function, balancing mobility and stability to fit its role in the body. And that's how the joints in our body are organized. If you know the classification, you're guaranteed to be an expert in joints. Every joint have a specific function, whether it's providing stability, mobility, or balance between both. And recognizing these differences is key to understanding how the body moves, how injuries happen, and even how to approach treatment in clinical practice. Now, let's take this knowledge a step further. We are going to go through all the joints in the body, starting from the top. The skull joints might seem simple, but they have a far bigger role than you would expect. Click here to watch the next video and see why. If you want a handmade PDF version of this lecture, take a quiz to test your knowledge, or access an organized list of all my videos, you can find everything on my website. Thanks for watching, see you in the next one.